Good day. We'd like to take this opportunity to thank the Diabetes Philippines Coordinator for inviting us in this prestigious conference. I am Dr. Luinio Tongson.
And I am Nurse Daniel Habawen.
So we are going to do the diabetic foot screening. Diabetic foot is one of the most complications of diabetes. It has a high morbidity, high mortality, and it is very expensive. In about 80% of non-traumatic amputation is secondary to diabetic foot, secondary to injury of the diabetic foot. So, in cases of chronic uncontrolled hyperglycemia, the patient are at risk or the patients will develop peripheral arterial disease or neuropathy or a combination of diabetes, peripheral arterial disease, and neuropathy. In peripheral arterial disease, the small vessel, the big vessels, and even the collaterals are affected. On the other hand, those patients who will develop neuropathy, it's either they will develop a motor neuropathy, autonomic neuropathy, or sensory neuropathy. In cases of diabetic foot, there is a combination of peripheral arterial disease and neuropathy and infection. So they are prone to develop infection and then eventually foot complications and amputations. For the International Working Group on Diabetes, there are different strategies in order to minimize or prevent amputation of this group of patients. One is to identify the patient who are at risk to develop problem of the foot. Second is prevention, and then we have to work hand in hand with our colleagues, the doctors and the nurses. So it should be a multidisciplinary approach. And then eventually, we have to prevent this complication. So the workshop for today is to identify those patients. So what is a foot screening done?
Okay, first of all, the foot screening or diabetic foot screening is used on diabetic patients. So the foot screening is a tool to assess the risk level of the patients, the diabetic patients. So we would know what to give education to them or when to refer them back to the physician if it's an emergency.
And at the same time, it will educate the patients and even the caregiver what to do in those patients. So, Dan, I think we have to go to the patient and assess our patient.
Okay, let's go to check a diabetic foot.
Okay, let's go. In assessing our diabetic foot patients, we have to take a good history, a thorough history, examination of the dermatologic condition, and the musculoskeletal deformity, and we have to do also neurovascular assessment. In the history, we have to know how long is the duration of the diabetes, and at the same time, what is the control of the blood sugar, the presence of amputation or previous amputation, history of bypass or angioplasty, and history of any other comorbidities. In the dermatological examination, we have to look on the skin of the foot of the patient. We have to look on the nails for nail dystrophy. Is there a hair on the foot of the patient? And then how about the dryness or the presence of calluses? And in the musculoskeletal, we have to look for the presence or absence of claw toe, hammer toe, or the presence of rigidity on the foot. And then we go to the vascular. So important is we have to go first to the history. Like we have to look on the signs and symptoms of peripheral arterial disease. Loss of hair, dystrophic nails, the presence of claudication, and then rest pain, capillary filling time, and then we have to assess the foot. Then, how are we going to assess the foot of the patient?
In assessing the foot of the patient, as mentioned earlier, we have to check for the dermatologic problems. if there are any deformities, and also for any neurologic deficiencies. So in checking for neurologic deficiencies, it's actually very inexpensive. And what we have to do is to check for the loss of sensation or loss of the protective sensation of the foot, which serves as alarm or protection. So in diabetic foot screening, we are going to use the Doppler, the neurologic hammer, the tuning fork, and the 10-gram monofilament.
What we don't have here is the BPT or the vibration testing. So in testing the neurologic status of the patient, the use of the monofilament can already say that the patient has a loss of protective sensation. Because here in the Philippines, we don't have the BPD, although in some institution we have this one, but it's not necessary. So meaning to say, if you have this neurologic hammer, this tuning fork, and this monofilament, it's already adequate then to know if the patient has a loss of protective sensation. Then can you show us how to get the vascular assessment or the ABI?
Okay, we'll go to that. I'll show you how to take the to check for the foot's neurovascular assessment. In this section of the presentation, I am going to show you what to assess in the foot of a diabetic person. So first, we are going to tackle the physical aspect of the foot. So we are going to look for deformities. We are going to check, as mentioned by Dr. Tongson earlier, the dermatologic factors that we can see. So let's check on the foot. So we have to check the physical aspect of the foot. We also have to check the interdigits of the foot, the web spaces, because you can have moisture here and it can start small wounds that can lead to infection. And of course, the nails. We have to check for any dystrophy, any possible fungal infections, and any friable tissues or even dry skin. In checking the skin, we can maybe tell signs that it has some vascular problems as well. So we can check for the hair growth, if there are any growth in the toes especially, or if none. If the leg is very thin, it is very shiny, and it's colored bordering on yellowish. So these are things that we have to check. For the deformity side, we have to check for the toes. We can check if there is clawing of the toes, if there are any hammer toes, and even charcot foot. And one very important thing is to check for the range of motion or the rigidity of the foot. So we have to try and move the foot somewhat like this. So after checking for the physical aspect of the foot, we have to document it.
Peripheral neuropathy is most important factor in determining the ulceration of diabetic foot patient. It is the most common pathway. In examining the diabetic foot, it is very important to assess the peripheral neuropathy by using the monofilament. So first is the monofilament plus the hammer, the neurologic hammer, and then we're going to use the tuning fork and the pinprick sensation, and even the cotton wool. So monofilament plus one test, then the patient has already loss of protective sensation.
Okay, now we are going to do neurologic testing for the diabetic foot. But before we proceed in doing any test or assessment, us healthcare workers must make sure that the room is well lighted or is well lit, and there are no distractions. So hopefully we can make it a not noisy room or a very silent room. So the first thing that we are going to use is the monofilament, the 10-gram monofilament. So before we test this on the foot, we are going to make the patient feel it in the upper extremities first. Okay? As an example, hello sir. Sir, ito po yung itutusok ko sa paa nyo. Wag po kayong matakot, hindi po siya nakakasugat. So ito po dapat yung maramdaman nyo sa paa nyo po. Pag naramdaman nyo po ito, itaas nyo lang po yung kanan kamay nyo. Okay? So pag may naramdaman kayo, ulitin ko lang po. Tataas nyo po yung kanang kamay nyo, sir, ha? Okay. That's one example on how to make sure that the patient understands the instructions. So let's go to the foot. So in the plantar of the foot, as you can see here, the old version of monofilament testing is to test 9 sites on the plantar of the foot. But today, the updated version is only to check 3 areas of the foot, of the plantar of the foot, and 1 on the dorsum. So if this is the plantar of the foot, we are going to check here, underneath the first toe, the third toe, and the fifth toe. Okay? So it is important for us to inform the patient that we are going to start. Okay, sir, bago po tayo magsimula, tingin lang po kayo sa taas, sir, ha? Huwag po kayong tumingin sa paa. Pag may naramdaman po, tingin lang po pag may naramdaman, taas nyo lang po yung kanan kamay nyo, ha? Okay po. Okay, as you can see, the patient has not really raised his right hand. Now, the monofilament testing can be biased. So, the areas that you should pick before using the monofilament should be an area where there are no calluses and any thick area. So, in this case, the toes, the plantar area of the toes are a bit calloused. So, we are going to transfer to a more softer area. Okay, sir, magsisimula na po tayo, sir, ha? Okay, so that's one example on how to do the monofilament testing.
Then, in addendum to that, it's very important that the monofilament should be buckled into a C shape, so like this one. And then, if the patient will answer yes or no, or raise the hand, or will not raise the hand, we have to validate 1 or 2 times in order to validate if the patients really have a loss of protective sensation. Thank you, Dan.
Okay. Now, after the monofilament testing, we are going to try the tuning fork. Now, this tuning fork, again, this checks for the sensation of the feet, and we are going to determine if the patient has any loss of protective sensation. So, the first thing we do is, again, to explain to the patient on what should he feel on his foot. So, again, we are going to instruct the patient using his upper extremities. So, the first thing to explain to the patient is that he has to feel the vibration of the tuning fork and not the pressure. And also, if he can feel the coldness of the metal of the tuning fork. Okay, sir. Ito-check naman po natin yung pakiramdaman ng paa nyo gamit po yung tuning fork. Ito, sir, pag patong ko po dito, hindi po dapat masakit. Okay, dapat mararamdaman nyo po na malamig ng konti o kaya mararamdaman nyo po yung pagnginig po. Nararamdaman po yung pagnginig sa kamay. Okay. Pag naramdaman po ulit sa passer, itaas nyo po ulit yung kanang kamay nyo. Ha? Okay. So, ulitin ko, sir. Ang dapat nyong maramdaman, hindi po yung pagdiin po neto. Dapat yung pagnginig po, saka yung lamig po. Okay po? Okay. So, let's try it on the foot. So, when doing the tuning fork test, it is important that we have to apply the tuning fork directly on a bony prominence. So, let's try it. Sir, magsimula na po tayo, ha? Sir, may nararamdaman pong lamig po sa paa? Meron po. Okay, so again, as Dr. Tongson mentioned, we have to validate maybe 2 or 3 times just to check if the patient really has loss of protective sensation or not.
And in addendum to that, Dan, but we don't have this machine here in the demo, the biotissue wherein there's a machine that we're going to test also more objective in the testing of the sensation of the foot. However, as Dan said, the monofilament plus this tuning port is already adequate to identify the patient that has loss of protective sensation. So if you're going to go to the research, then you can use the machine, the biotissue.
Okay, now, most of the questions that we have is, what if we do not have the monofilament test? One thing that we have easily access to is the pin or the needle that is not really that sharp. Again, we can use this to check for the sensation or loss of sensation of the foot. But first, we have to always let the patient experience it in the upper extremities first so that they would know the sensation. Okay? And one important thing is make sure that you do not penetrate the skin. You just let them feel the tip of the needle. Okay, so again, sir, may ilalagay po ako sa paa nyo, hindi po kayo masusugat, wala pong masakit na mararamdaman. Ganito lang po yung mararamdaman nyo po. Nararamdaman nyo po ito? Okay. Hindi po kayo masusugat dito, sir. Hindi po ito masyadong makakatusok sa inyo. So, when you explain that to the patient, again, you go back to the foot and you just do look for any areas that is not calloused or the softer ones. So, you just put pressure on the skin a little bit using the pin. And, sir, may nararamdaman po? Okay, sir, magsisimula ulit ako ha. Pag may nararamdaman po sa paa, tataas lang po sa kanang kamay natin. Okay po? Sisimula na po ako. Okay. So, after the pinprick testing, we are going to proceed to check the sensation of the foot using the tuning fork, or the neurologic hammer. In this section of checking for the neurologic aspect of the diabetic foot, we are going to elicit the deep tendon reflex. So, we are going to use the neurologic hammer. Now, in our experience, we have to put the patient in a comfortable position where the foot or the leg is not stressed before we try to elicit the deep tendon reflex. Okay. Now, in our experience, we put this patient in this position. He kneels on one stool, and we point the toes towards the knee. After achieving a comfortable position like this, we are going to hit the Achilles tendon and try to elicit the deep tendon reflex. Okay, so in this case, the patient has a positive result for the deep tendon reflex. Now, that three, the monofilament testing, the pinprick sensation, the tuning fork, and the neurological hammer, more or less we can decipher if the patient has loss of protective sensation. We have to check for the footwear because since peripheral neuropathy or diabetic neuropathy is the cause of the highest cause of diabetic foot ulcers, and the footwear is one of the most common causes in Southeast Asia because us Asians are fond of using flip-flops or bare naked slippers like this. So after checking for the neuropathic aspect of the foot or the sensation of the foot, let's proceed in checking the vascular.
In the vascular assessment of diabetic foot, it is very important to go back to the history of the patient because ideally, we have to know first if there are signs and symptoms of peripheral arterial disease. About 1/3 of our patients in peripheral arterial disease will lead to chronic non-healing wounds. And the signs and symptoms includes but not limited to absence of hair, as Dan said a while ago, the presence of blanching. We have to check for the capillary refill, and then we have to look for the presence of claudication, or in severe cases, rest pain. And of course, we have to palpate the pulses, such as the femoral pulse. We have to check for the femoral pulse, and then we have to check for the popliteal, the dorsalis pedis, and the posterior tibialis. So in our clinic, what we are going to do is to do a screening, the ankle brachial index. In the ankle brachial index, we have to get the systolic pressure of the ankle divided by the systolic pressure of the brachial area. In the brachial area, we have to get the highest systolic pressure. And in the ankle, what we're going to get is the dorsalis pedis and the posterior tibialis. The highest pressure on the ankle area, it's either the dorsalis pedis or the posterior tibialis, will be used for the computation of the ankle brachial index. Normally, the value is 0.9 to 1.2. If the ankle brachial index computation is less than 0.9, then this patient has already peripheral arterial disease. The lower the ankle brachial index, the severe the atherosclerosis. In cases wherein your computation is more than 1.2, then meaning to say it's a false positive because there's already a medial calcification. In such cases, we have to request for further studies like the duplex scan. Dan will show us now how are we going to do the ankle brachial index. So Dan, can you please show us how to get the ankle brachial index?
In this section of the diabetic foot assessment after the neurologic exam, we are going to check for the vascular aspect of the foot. So as mentioned earlier by Dr. Tongson, first we are going to do the easiest vascular assessment of all, which is to check for the pulses. So the sites were mentioned earlier, but in this part I am going to show you how to do the ankle brachial index. And we are going to need the Doppler, the BP cuff, KY jelly, and of course, something to wipe the KY jelly with. So the first thing that we are going to do for the ankle brachial index is to get the systolic pressures of both upper extremities and lower extremities. So first, we are going to check for the systolic pressure of the upper extremities using the Doppler. Okay. One technique in getting the pulses, you palpate it first so that you would know where to place the Doppler. So we are going to use KY jelly and the Doppler. So as you can hear, there is a strong pulse audible in the Doppler. Okay, now that we have done that, we have gotten the systolic pressure of the left brachial artery. Now for this, for the ankle brachial index, we do the same procedure for both arms. So after getting the systolic pressure of the left brachial artery, you document it, then take the right brachial artery and you document it also. Now I am going to proceed to the ankle systolic pressures. Now we are going to check for the ankle systolic pressures. Now before we check for the ankle systolic pressures, we make sure that the feet is not elevated and is flat on the bed. First, we check the posterior tibia pulse. Again, it's better if you have palpated the pulses first so you would know where to place the Doppler. So after taking the systolic pressure of the posterior tibialis artery, we go to the dorsalis pedis. Again, make sure to palpate first the dorsalis pedis artery so that you would know where to place the Doppler. Okay. Now we have gotten our data, the systolic pressure of both upper extremities and both ankle systolic pressures. Now, we have gotten the posterior tibialis systolic pressure and the dorsalis pedis. So we just have to pick which is the highest systolic pressure and we use that with our computation. Now, the computation will be the highest pressure of the ankle of one side, for example, the left. Then we divide it with the highest systolic pressure of either side for the upper extremities. So the formula will be posted in the video. So after that, we collate our data starting from assessment from the physical aspect of the foot, the neurologic, then the vascular assessment, and we give our assessment and show it to our physician.
So the importance of diabetic foot screening is to classify the risk of our patient and at the same time to know when to follow up the patient and education for our patient. It seems that the foot screening is a little bit long. However, there's no reason that we cannot do the diabetic foot screening because we have the 3 minutes foot screening done. So in first minute, what we're going to do, we're going to ask the history of the patient, the duration of the diabetes and its complication. We have to ask for the previous surgery or presence of or previous ulcer, amputation, previous angioplasty, or bypass of the peripheral arterial disease. And of course, we have to look also or ask for the burning or tingling sensation for the neuropathy. So that's only 1 minute. And for the second minute, done.
For the second minute, also we would need only 1 minute for this. So we are going to check for the physical aspect of the foot. It's simple. We just look at the foot, we look at the nails, we look at the skin of the patient, and we look at the signs and symptoms of possible neuropathic and vascular insufficiencies.
And then for the third minute, what we're going to do is to educate our patient. This is very important because with doing this one, if we don't educate the patient, it will be useless. So we have to educate the patient that they have to put lotion, they have to do exercise, stop smoking if they are smoking. Education is very important. And what else then? What we're going to educate our patient?
Also, another thing for education, especially for diabetic patients, is the importance of proper footwear. Now, because the most cases of diabetic foot ulcers is because of neuropathy. And due to that, the specific cause is actually the most highest cause in Southeast Asia is because of improper footwear. So we can look at that when they come in. So before seeing the patients, we can actually just see the footwear first, then go to the patient.
So do you think then we can do examination in 3 minutes?
I think we can.
Yes, we can.
Yes, we can.
We can do it.
We can do it.
So anyway, after the diabetic foot screening, we're going to, as we said, we have to educate, and then when are we going to follow up these patients? So we can look on the International Working Group on Diabetic Foot and the American Diabetes Association for the follow-up and when to refer or what are we going to do to our patients after a proper diabetic foot screening. Dan, can you say a little bit to our patients?
Okay, now, again, to our diabetic patients, it is very important for us to take care of our foot, but it is important for us to check our feet daily.
And at the same time, we have to involve our patients in this proper care because, as we said, we have to educate the patient, and then the patient should do what we're educating to our patients. So, in behalf of Dan, we would like again to thank the organizer of the Diabetes Philippines and of course our model,
Our most cooperative diabetic patient.
Mr. Leo Basaka. Thank you very much and good day.